in the new customary Teams etiquette. And if you want, please share details of where you're from, what service you're from, that kind of thing.
Yeah, absolutely. So it's good to see lots of familiar names and lots of names I don't recognise as well, which hopefully means that our network is growing. So yeah, if people could say who they are in the chat. I'm Jenny Drive, so I'm chairing. I'm the consultant in the START team, which is a mental health team for rough sleepers and SLAM, and I'm the College of Psychiatrists advisor on homelessness. Good. So let's make a start. So this is the 3-monthly, there's a better adjective, I'm sure, meeting of the Faculty of Mental Health run by Pathway. Alex has just introduced himself as Chief Executive. These meetings were started probably about a year ago now as an opportunity for people who work in mental health with rough sleepers to get together, get to know each other. So part of it is to hear speakers, but another part of it is to network and to chat as best we can, which is partly, I suppose, prompted by COVID, things happening more virtually, but I think it's been a really good thing for us all to get to know what's happening in other areas. So what we're going to do today, we're going to have a talk from Barney now, and then we've got Rup coming at 11:15, and in the middle we're going to have a discussion about safeguarding, which Alex is going to introduce. But the more conversation we can get going, the better. So at any stage, if people have questions, if you write them in the chat, and then when we have more conversational bits, just put your hand up and I will do my best to chair it effectively. So Barney, I'm going to hand over to you. Barney, I think a lot of people will know, he's the director of EASL, the Enabling Access Service for London. But Barney, over to you.
Hi, hello everyone. Yeah, and thank you for sort of asking me to speak. I've put some slides together and I'm going to sort of share them. I think it may be quite sort of conversational anyway, however, so let's see. I mean, my point really was to, to talk about EASL, which is a relatively small organisation which has grown up over the last 10 years. And I think I can sort of describe what we were responding to and how we've worked over time and the context in which we've been doing it. And I suppose it's, on one level, it's just an excuse to talk about what we do, but I sort of think that it might be quite a useful way of sort of looking at how things have changed for the sort of sector as a whole, and especially the role of specialist homeless mental health services, and the sort of the challenges sort of going forward. So EASL is a social enterprise, and I suppose the concept came up in 2000. At the time, I was working in Camden and Islington, where I'd been manager of the homeless mental health team initially, which covered Camden and Islington, and then the Islington service, which was decommissioned. And I guess in that final year of that service, No Second Night Out started, and their initial assessment hub was in Islington. And I suppose I was sort of struck by the way the local NHS trust and local authority responded to that there was going to be a challenge really for pan-London services to sort of access timely mental health assessments for people who didn't have a strong local connection. And I suppose that was always one of the sort of potential needs which was identified. Alongside that, in 2011, the MHCLG, as was, sort of published its first sort of PI guidance, and again, looking at that with Tara O'Neill, who was at the time the dual diagnosis lead and a clinical psychologist in Candy. We were sort of struck really how it reflected our own direct experience in the focus team, where we had some of her time as a psychologist, but the most effective way of using that often was in sort of supporting the work of the voluntary sector commission teams in their work in working with people with a history of complex trauma, rather than necessarily always some direct work. And I suppose those three factors of the service being decommissioned, the rise of pan-London services, and the sort of pie conversation seemed to make it apparent that there was a need for a service. And actually, Jenny Drife was in an early conversation. We'd worked together in the focus team, and the organisation was sort of founded in the end of 2011. It's a community interest company. I won't go through those sort of objectives, but they haven't changed. They're still sort of very much sort of what we do. And I suppose the tasks carried out really from the start and still relate to sort of assessments, advice, and sort of capacity building, including training and reflective practice. We always sort of operate in sort of partnership with another organisation. We are sort of we're not set up in such a way that we work directly with clients unless they're already linked with someone. And again, actually, with even things like the reflective practice and the training, we would largely do with an organisation we were working with in a more broad way, rather than just coming in and offering a sort of one-off or one-dimensional service. I mean, in terms of our assessments, I think one of the crucial things is that we're not assessing to a sort of threshold necessarily. You know, very often we are working, and I can give some examples of this, with a homeless organisation, who and they might have a service user or a client who they feel might benefit from an assessment, but we would always, I suppose, the function of it might be quite varied. It might be that our assessment would support access to a secondary mental health service. It might be that our assessment in itself will demonstrate entitlement to housing or something of that sort. It might be that the assessments end up relating to sort of mental capacity of someone to make a specific decision, and it can be that they improve an understanding of what could be going on for that person, and that might support the approach of the service. I think, you know, our assessments would always sort of relate to the context that someone's in, you know, the EASL practitioner's sort of understanding of different parts of the system is going to be important. I said these slides were going to be a bit haphazard. I haven't really said who works for EASL, and I suppose the crucial thing is we're all mental health professionals operating at a sort of senior practitioner level. And we're significantly sort of social work, but also occupational therapist and sort of CPN. I'll look at I'll show you some numbers sort of briefly in a moment. I think all our costing and pay is linked to NHS bandings, and I think we're sort of committed to not being seen as an alternative to NHS services. We don't offer treatment, diagnosis, or sort of casework. And I think it's quite sort of relevant, and I think a positive really, that 90% of our funding at least really comes from housing sources. I suppose, you know, we don't want to position ourselves as a sort of an alternative to local health commissioners supporting provision by local statutory sort of providers. But I think it's quite, I feel that we have demonstrated that there's a value in us sort of oiling the wheels, supporting those other services to be able to support the people they work with to access services, and I think that that's really where we sit in. We're multidisciplinary, as I was saying, and I think one of the useful things we're able to do is offer quite small amounts of input to support individual projects. I'll go through some of the projects we work with shortly, but I think quite often we might be providing, you know, the equivalent of 1 day a week of senior practitioner input to a project. and I think I think the sort of caliber and experience of our workers does mean that can make a big difference. People are able to sort of attend to sort of support a project with sort of case discussions, direct assessment work sometimes. We also, you know, often alongside that would provide reflective practice and training. We don't have an office base. We sort of the practitioners. I mean, well, we do have an office base where I am, but it's an administrative office, which is actually in Hertfordshire. But we don't have a base from which the sort of clinicians are sort of based. People go to projects, and we use sort of mobile sort of technology a sort of fair amount. And I guess, you know, expansion isn't a goal. I mean, we do seem to be expanding despite that, but I think it's sort of it's often quite an interesting balance we're trying to sort of play, where we obviously want to sort of sustain ourselves and be sort of viable, but not to get into a position where we are sort of bidding for things because we could. We want to be very specific and be used where we're sort of needed, and to support the system as a whole to be more sort of joined up and work more effectively. And we've been quite involved, as I'll get on to, in the development of some sort of statutory services in fact where there's been a period where they haven't been present. So just to sort of give you an idea, in 2012, the work we were doing included, the very first thing was some training for housing justice, some ad hoc assessment work with London Street Rescue, which Jenny Drife was involved in. And we started working in No Second Night Out in the West Hub, providing assessments in West London. I can clarify later. I'm going to work on the basis that people may be familiar with No Second Night Out as a project. And we started then actually doing broadly capacity building work in Hammersmith and Fulham hostels, and that continues to this day. I delivered training for AMPs, and I should have said, I mean, my background, as I said, is a mental health social worker, and I've previously been an AMP. So quite a few people in the team still work in statutory services 1 day a week, or sometimes more. So at the beginning of the year, EASL consisted of me 1 day a week. By the end of the year, it was sort of equivalent of 2 whole-time sort of senior practitioners, really. And Tara O'Neill, who I referred to, was working with us 2 days a week. At that stage, as an organisation, we did use sort of ad hoc sort of psychiatric input sometimes to sort of carry out an assessment. I'll get onto that because that's something we've stopped doing, and I think there's a sort of rationale behind that, really, which is partly about how we do position ourselves and not wanting to be seen as a sort of alternative to what statutory services ought to be doing. Okay. By 2020, the writing's got a bit small here. We'd expanded quite a lot. We're sort of now equivalent of, I suppose, with admin support, around 10 posts. 2 of those funded by the GLA, directly to work with the sort of street outreach teams in areas of London which didn't have statutory homeless mental health provision. We work with sort of the Thames Reach projects with their Star project, the outreach teams there, and working in sort of hot spots and with sort of people referred to there. And we worked a lot with St Mungo's, actually, in a large part with their pan-London services, and I suppose just especially I mean, clearly we're a London organisation, but I hope I haven't been too London-centric in what I've said. There was a change in the sort of late noughties, where some of the funding for homelessness, which went from central government to local authorities in London, went to the Greater London Authority, and so they started commissioning various pan-London services, which I think have been effective in their own way, but clearly there's a challenge there when they cross health commissioning boundaries sometimes, and I think there's been a very specific role for us sort of there. And a lot of the Mungo's projects we've worked with have been their pan-London projects. Then we've also had direct arrangements with Westminster, Hammersmith and Fulham, Islington and Newham, Westminster and Hammersmith and Fulham very much around the sort of working alongside their commissioned homeless projects, with sort of case discussions, reflective practice, sort of training, occasionally some relatively sort of discrete assessment work. But when it's in a sort of local area of that sort, we would more generally see our role in terms of capacity building. We've also been involved in writing a fair amount of guidance, which is for Homeless Link. I think we probably should have promoted more, because it's a really useful document. The guidance for mental health professionals around working with homeless people, actually, I think is quite useful, but also a lot of it geared more to around sort of various issues about supporting homeless organisations to navigate mental health services. And I'll get on to the whole sort of mental capacity area, which we've done quite a lot of work in. Our OT has supervised a number of OT students who'd been on placement with housing organisations, but she's been giving them professional supervision. In the years up to 2020, really, we were quite involved in the whole conversation with the sort of GLA about the commissioning of statutory homeless mental health services, the RAMP teams, and we sort of remain quite involved with that. And I think what is interesting really is by sort of 2020, we don't use doctors or psychiatrists to carry out some ad hoc assessments. I suppose our feeling being that you know, even if that might be something which someone could benefit from to access the treatment they need, given that we don't offer treatment, we don't offer those sort of statutory assessments. I think there's almost a clarity in us providing a hopefully authoritative, well-informed, considered, trauma-informed assessment by a social worker or a nurse or an OT to sort of support the case, maybe if it's needed, for a statutory service to get involved. And I think if we start getting into conversations about diagnosis and things of that sort, then I think it almost puts us in a sort of different position where we're having a different sort of conversation with local statutory providers. Just a quick sort of snapshot, I suppose, of some of the projects which we've been involved with over time. So saving lives, I mean, that's interesting, and miserably as well, it was one of those, I think, quite important projects which grew out of recommendations from a serious case review when a man in Lambeth died on the streets in 2010, and one of the recommendations was development of better guidance for outreach workers, for example, around assessing capacity of people who were sort of street homeless. And it was a sort of consortium involved. Pathway sort of hosted it, and the guidance is still out there, and we had some training for a number of years, which sort of EASL sort of project managed, really delivering training to different local authority areas, different groups of health and para-health sort of professionals and homeless people. I think that guidance is still very useful. It might be quite interesting to revisit that with in the conversation which is going to be later on this session. I don't feel that the mental capacity screening tool actually is dated, although it's some time since it was revised. I think it's a very useful tool. And I suppose that was an example where we slightly stepped out of our model and did take on a role involved in some training which wasn't linked to sort of other aspects of delivery, but it seemed so central to what we're trying to achieve that it seemed important. I mean, Westminster Hostels, that has been an interesting piece of work. So we've been involved there since 2015. Partly based on what we'd been doing in Hammersmith and Fulham, and we sort of very much sort of worked across the hostels. Again, a lot of capacity building, some sort of case discussions with different hostel teams, reflective practice and sort of training. As things developed there, it was interesting. It was sort of re-tendered as a sort of bigger project, and was sort of was won by Slam, which was interesting, and sort of they've done great stuff there sort of since, with much higher proportion of psychology input and much more sort of link there. But EASL has sort of carried on doing some relatively discrete bits of work there, some incident debriefs, some OT assessment work, and some in some areas of case discussions and training. And I think it's been quite an interesting example where we've sort of almost been able to sort of be involved in supporting a service to start something off, which they've then been able to commission on a larger scale, and I think that's been positive. The ramp work's been, the development of the ramps has been very interesting, and I suppose if people aren't familiar, I know there's a few ramp representatives here. There's a GLA sort of gave sort of funding to different NHS trusts to set up multidisciplinary homeless mental health teams in areas where there weren't some in London, not in every area. And again, I think it was one of those sort of things where you know, various different ideas which were sort of suggested earlier on might have included EASL being more involved in sort of direct sort of delivery and expanding that, but I think that wouldn't have been a good use of what we do, and instead it felt quite positive being able to support and influence the development of those services, and we remain quite involved in sort of stakeholder meetings, etc., and work alongside them, but probably with quite a different role in an area where they're based. I think safeguarding we're going to be talking about later, but I don't know. I'd so recommend anyone who hasn't read the Shah for the man who died in the bus stop in Hackney in 2019. EASL had some contact with that man. We'd been involved in some of the sort of referrals which maybe weren't acted upon as quickly as they might have done, and but I think we maybe hadn't been so strong as we could have been in advocating more strongly alongside the homeless organisation who was working with that person to get a safeguarding review happening before things turned out as badly as they did. And I think that sort of that was been a good learning opportunity for us, and we've been quite involved since then really in some of the expert reference groups around safeguarding, and the book which is being published yesterday about safeguarding and adult safeguarding and homelessness, there's a chapter in that which we've contributed to. But I do think, working across a number of different areas of London, we do see how much practice in some areas has been influenced by the sort of increase in focus on the use of safeguarding, and we think it's very, very important that gets more widespread and continues. I mean, during the pandemic, it's been an interesting time for us, really. I think in some ways our model lent itself fairly well to be sort of redeployed quite quickly. Clearly, a lot of the projects which we had been working with, indeed a lot of the contracts which we had, was to support projects which suddenly didn't exist. So there's a sort of no second night out hubs, which probably constituted 40–50% of our work, where people slept on the sort of floor of the places suddenly didn't exist and the hotels were set up. A lot of the teams we worked with were sort of redeployed, and we were very busy in providing assessment input in a number of the hotels and being quite involved in a lot of those sort of discussions. And I think it was quite interesting, and I mean, not important, but certainly a little bit annoying from our perspective at times when people were talking about, as if it were a new thing, the challenges of linking people who were being helped by a Pan-London project into health services, which was something which had been our meat and drink and the challenge we'd been struggling with for a long time. And suddenly this sort of being talked about as if it had never been a thing before. But I think it's been a very positive experience in terms of there has been an increased willingness for sort of statutory services, but at least in the height of the pandemic, to sort of work across those boundaries and to be a bit more sort of pragmatic and person-centered rather than finding reasons for not taking people on. And so that's been quite interesting and positive. I think one of the things we reflect on, though, is the impact these constant changes have had on the people working on the front line. I'm particularly thinking about the housing workers. And I think that sort of command and control crisis response to sort of delivering healthcare or services, housing services in a pandemic were probably necessary and indicated and helpful. But I am concerned that the sort of people spending most time with the service users and people experiencing homelessness have had a very, very difficult couple of years, and they've had their working conditions and the pressure on them changing sort of constantly, often with very little notice and very little sort of say. And I think I say that for reasons about being concerned for their welfare, but also just the reflection that I think it's going to be very difficult for frontline workers who are going through that level of loss of control and change in their life to be present and with people who probably themselves have, as we all know, very high levels of complex trauma and other issues. And I think that's a real challenge for the sector going forward. I'm going to just sort of, as I apologise, I've slightly sort of chucked these slides together, but I think I've just sort of a number of points here, which is, I think, things for EASL to reflect on. But I think there might be something here, which is, there might be things for other people. I think one of the things we're doing now is we've sort of slightly restructured our psychology input. We're having much more structured time as a team in terms of development days, looking at our approach, making, I think to a large degree it's giving our practitioners, who I think always have been very sort of reflective and thoughtful in their approach, but giving them more ability to be more sort of explicitly trauma informed, I suppose, in how they carry out their tasks, how they write things up. I think there's something there about us strengthening our ability to push back on those who commission us sometimes, and to talk about to push back against the sort of sometimes the for example, monitoring requirements, which are all about sort of relatively easily measured outcomes, which might not make sort of sense for someone who is in a position of who may not be able to make a decision, for example, about a single service offer quickly because of their experiences of life and sort of services in the past. And I think there's something quite interesting there. I think we're always looking at the way we incorporate a user service, a service user as sort of perspective. I think there's a challenge for us, because basically we're a bunch of senior practitioners delivering a relatively specialist input. You know, we're not well placed to give placements for sort of professional training, for example, and I think this very specific function we do sometimes doesn't lend itself well to you know, we're there in a very specific professional role, but we have in lots of our training from a very early stage, and some of our sort of stakeholder meetings, we do have involvement by people with sort of lived experience, but I think it's something which we need to sort of think about more, and try and do more effectively. Evaluation is another area where I guess we could improve. I think partly the nature of the way we're funded to work in quite sort of small ways with a specific population, and the sort of funding is often very linked to sort of, you know, supporting an outcome of a bigger project. It is quite difficult, I think, to evaluate our input, and it's been quite difficult to advocate and get funding to support more evaluation of what we do. I do have an idea at the moment, which I want to explore more, but I think it's too early a day, too early to sort of try and incorporate some more of that. One of the projects we're looking at sort of redesigning at the moment. I think one of the most interesting things for us, though, and one of the sort of opportunities and challenges is, I think we were sort of born at a time when statutory services were being decommissioned, and we're now at a time where statutory services are being commissioned. And I think we very much positioned ourselves as sort of, you know, not having a role where a statutory service was present. And I think we partly did that because we wanted we wanted sort of the case and the need which still exists for services which could provide treatment and statutory assessments to be there, and we didn't want to be seen as a sort of cheap alternative to that. But I think what's become clear to us, and it'd be interesting if other people, I mean, I know Jenny actually would have a perspective, is actually in the last year or so we have been working, and partly because of changes because of the pandemic, we have been working, for example, quite a lot in the same areas, supporting some of the same projects as, for example, the START team in Southwark in one of the COVID hotels, and with some of the homeless outreach clients in Westminster, where there's already the sort of joint homelessness team. And I think what we're sort of recognizing, and what is being recognized, and that's been straightforward, that working in the same space, but you know, we're seeing people for whom there probably isn't a likely role for secondary mental health care or secondary mental health services in the short term. But I think there is something about the our assessments which can greatly support that person and that project, trying to help that person access things in terms of how they might relate to them, but also, you know, the details of their needs in terms of future support and reconnection and any of those areas. So and I think going forward that's going to be quite an interesting thing. One of the challenges for us, I think, is just getting the right balance about, you know, what our profile and influence should be, really. You know, as I've said before already, we're a bunch of mental health professionals. You know, we've got sort of relatively small overheads because we don't have a comms department or you know, and we're sort of generally sort of, where we are commissioned, it's to do something relatively direct, and yet I think we do have a very useful, I would say sometimes important perspective, and I think it's sort of finding the right way for us to be involved in those conversations without it becoming what we do at the expense of sort of what we are best placed to do, which was what I've already described. And I think we're still faced with this sort of balance of sort of sustaining the organisation, sort of identifying where there is a real need for us, and being sort of viable into the future, but at the same time sort of doing that in a way which isn't sort of defensive and stops us from being able to offer proper sort of considered objective advice to sort of, for example, commissioners in the areas where we're working, where we think that sort of, you know, it would be better for the solution to be found which didn't involve us, or a service to be developed which involves someone else. So I don't know whether that's a relatively specific EASL question, or whether that's also sort of something to which might have resonance for other people as well. I mean, I just, you know, and I'll just go back because I've said it before in these meetings. Actually, I also endlessly sort of think that we, as the people represented in this virtual room, I suppose, I do think there's always going to be a matter of thinking about that right balance of having specialist services for people experiencing homelessness and using our expertise to support more general services to offer a more effective, appropriate service to people who are experiencing homelessness. And I think if there's anything about that final question, maybe which might be sort of relevant to this room, I wonder if it is about sort of thinking about how we position ourselves in relation to trying to get the right balance in relation to that question. I'm thinking that that's all I had sort of prepared, but I'm very happy to sort of go back on anything, or, you know, if anything I've said provoked a conversation which doesn't involve me, then that's good too. But I'll hand back to the chair and see what people are thinking.
Thank you, Barney. That's really great to hear about EASL, and I'm echoing. Am I echoing elsewhere? Oh, it's because you're now on mute. Yeah, really great to hear about EASL and sort of looking back over the years. As you say, I was involved peripherally at that outset, but now you've gone on to great stuff. It feels like you're getting bigger and bigger, even despite not wanting to expand.
Yeah. And I think that's a challenge as well, because I suppose it's not wanting to sort of change what we, you know, it's trying to get that right and not sort of expand beyond so that we turn into something different. But sort of trying to sustain something there. Yeah.
So just to say, if people don't have the chat open, please opening it, because there's a few links, useful links that have gone up. The guidance for mental health services working rough sleepers that you mentioned with the mental capacity forms, and I think it's got guides for mental health act assessments too, which we use a lot actually. Still, we always give it to new people working, so that's still very much an active document. And someone put up the safeguarding advice by Michael Peston Shoot, so all these links are in the chat. There's a question about the book that you mentioned. You mentioned the book that you've written a chapter of.
Yeah, well, I wrote, I'll find the link. Jessica Kingsley, you can order now if you go on to the I'll put a post up there. If you it's edited by Michael Preston Shoot and Addy Cooper. It's got contributions from a number of people. I haven't read all the chapters yet. My copy arrives tomorrow. I think it's going to be. I'm feeling very. I think I don't know how many people will be giving it to receiving it as a gift at Christmas or whatever, but I think it's going to be a really useful compendium of quite sort of thoughtful, well-informed, well-referenced discussions around a really important area. Brilliant. Nigel's got it.
Yeah,
right.
Well, maybe we'll all give it to each other for Christmas. That would be nice. There's a question about safeguarding, so we're going to move on to a question about safeguarding, but I just wanted to ask, because I know we, as you say, have been doing sort of work in mutual projects, which has seemed to have worked pretty well, I think, but I wondered what the response from other more generic services, NHS services, has been to the presence of EASL. Do people welcome your reports, or do they think there's an annoying thorn in our side again?
I mean, I think it varies really. I mean, I sort of feel that I think it goes back to slightly what I was sort of saying about the sort of not having doctors involved. Possibly in a funny way, you know, we're able to position ourselves as sort of presenting a sort of compelling case that they might need actually look at what their duties are and carry out, rather than sort of getting into a tit for tat sort of argument about things. A phrase I often use is, it's just trying to get into a situation where there's a better quality of conversation. I do think there's a big thing in my experience, and this goes right back to the 90s, where I was a project worker for St Mungo's myself, where I think, you know, we all will have witnessed it. You get the least qualified people in a homeless project sometimes holding a huge amount of the anxiety and risk, and their concerns just not being acknowledged sufficiently or taken on board by the organisations which ought to be taking that on board. And I often feel that our role is trying to sort of oil the wheels of that conversation. And I think there's also something about sort of expectation management of everyone involved there, of sort of, I think, trying to reframe requests for input, not as, please take this problem away from me, but we're finding it really difficult to help this person. We're really concerned about this. You might not have a role as a statutory service, but can you offer us an assessment which might support the way we're approaching this? And I think what we're often trying to achieve with our assessments is to sort of get that conversation going, rather than sort of saying, this is what you need to do. It's trying to say, we think there's likely a role for you for these reasons. Please have a look at this. And I think when we can achieve that, it works quite well. But inevitably, some systems are built to make that conversation quite difficult.
Well, I must say, I think the beauty of your team is the standard of the assessments and the reports that you write, which are phenomenal. They're so useful to have for our team when they come in. So I imagine that a lot of other services must welcome having them. Really useful to have in someone's notes, for example.
Yeah, I think that, you know, it's striking to me. I sort of do work in I work 1 day a week as a tribunal member, but I'm really struck at how poor quality I think it would be very interesting to look at the quality of reports and the writing in them, and the detail and the consideration and the reflection which goes on within a lot of reports within NHS mental health services now is far, far worse than it was 15 years ago.
Mm.
You know, the superficiality of the conclusions reached, the lack of consideration of the wider system is sort of troubling. And I think sort of sometimes I almost see sort of EASL as a sort of arc of trying to keep quality of sort of the report writing and assessment sort of sustained, because I think it's difficult to achieve that in the NHS, evidently, based on the quality of what you see sometimes.
Absolutely. Yeah, it would be a nice project for someone to look at that quality of the reports. We need to move on. Alex has had his hand up for a while. Alex. Well,
I mean, actually, I'm tempted to ask a question about what you were just saying, Barney, because I think, I mean, I'd be really interested in your long views as to why that's happened. Why has that quality fallen in? I think you're referring to kind of more mainstream mental health services. Certainly the pathway teams often work closely, for example, liaison psychiatry teams. Is it those kind of assessments, or is it even more broad than that? But my actual question was more related to, you talked about reflective practice as being something which partly feels like it's grown in presence and recognition over your history, as it were. But equally, we still struggle hugely to get anyone within the statutory sector, like the National Health Service, to actually fund it, to actually put any investment into supporting staff teams. I wonder whether you had any thoughts on, I mean, is there an evidence base? Because we keep going around, should we be pushing much harder to get reflective practice funded, particularly for the teams who are working in that kind of very frontline client-facing space? How do we make the case?
I think I tell you what, our current sort of principal psychologist, Rachel Brown, is really good on this stuff, and I don't know if anyone else has sort of come across her, and certainly some of our comments for the NICE guidance were written by her, and a lot of it reflected to that, sort of referred to that. So I can sort of I'll sort of talk to her and or just sort of nick what she's sort of written in relation to that. I do think it's a big area, you know, but reflective practice also. The problem is, for me, I think sometimes it's understood from a sort of managerial point of view as a space in which people can ventilate and get rid of some of their frustrations, and actually organisations are impervious of sort of learning and changing their practice based on some of the things which might come out of that reflective space. And I think that there's a challenge there. It's not just about sort of seeing it as a sort of add-on to sort of bring in to sort of as a sort of SOP for staff teams to sort of help manage their welfare. I think there's also something about needing to sort of commit to sort of a culture in which that sort of reflection is incorporated into how we approach the work and look after each other and hear each other and talk to, you know, it's a broader issue, I think.
The kind of system change piece, almost, that there are lessons to be learned from what comes up in those groups, and we, yeah, that's really interesting. Might I have a second question, Jenny? Is that all right? Well,
I'm keen that we have some time to think about safeguarding before the next speaker. Is it a quick question?
Well, just, I mean, I don't know. Very. You talked a little bit about the balance between mainstream and specialist, and your role. What the role of services, particularly inclusion health services, is in that space, and what's. I guess I didn't quite hear your conclusion as to what you think the answer to that question is.
I think it's difficult, and I think there's sort of horses for courses. I think sort of sometimes you might have an area with a relatively small number of sort of people who are in a particular sort of cohort, and it probably isn't particularly timely or sensible to try and set up a specialist service there. But what is needed is to acknowledge that there is some complexity there, and it's important to try and bring in some sort of experience of practitioners to support the development of services. I'm very mindful of something I associate with Nigel Hewitt saying, but I think I remember Jane Cook corrected me and said he didn't originate it, about homeless people experiencing homelessness can be seen as a litmus test. A service which is better at supporting people who are experiencing homelessness is going to be better at supporting all sorts of other people. And I think there's something really important there that we don't sort of, it's almost about sort of acknowledging the value we in this room have as well to support services more generally be better at supporting a whole wider range of people. And if I'm involved in AMP training now, and I just sort of think, you know, I can talk till the cows come home about sort of what makes sort of, you know, the challenges of setting up an assessment and carrying out an assessment on the street of someone who's street homeless. Not much of it is rocket science, really, and most of it applies to other complex community mental health act assessments. And I think there is sort of something about, you know, us being confident about supporting wider systems to learn from the homeless sector and what's important and only can work here as well.
Wise, very wise as always, Barney. Thank you. I am going to move along. I see Dee, you've got your hand up. Is that a question that you asked about safeguarding? Because I was hoping, if it is, I was hoping that Alex could introduce what he wanted us to talk about as safeguarding, and then we could use that as part of the conversation on that. Is that all right?
That's fine, and I think Alex knows what I was going to mention anyway, so it'll all be seamless.
Perfect. Okay, as if we planned it. That's great. Alex, over to you.
I'm not sure how seamless it will be, but yes, just to share with colleagues. I mean, we're partly seeking colleagues on the call's advice and thoughts at an early stage. So a bit of background. Pathway has become a member of a consortium with Homeless Link and Groundswell, some of whom have been mentioned on the call earlier, and a member of this weird thing called the VCSE Alliance, the Voluntary Communities and Social Enterprise Sector Alliance, which is a strange Department of Health funded network, which you generally don't need to worry about, except it brings with it layers of bureaucracy for us to battle with. However, within it, we get a small amount of funding every year, and we are duty bound to come up with 3 so-called projects per annum. And we're just looking at projects for next financial year, which will be 1st of April onwards. Particularly thanks to Sam Dorney-Smith, who's on the call. We've been wondering what to do, and it's not very much resource, so it's kind of 5 or 10K, so it's not a huge thing, but it brings a focus, and through that network has connections both to the Department of Health, to NHS England, so potentially quite influential. Sam raised with us, I mean, some of what you were talking about, Barney, but we've been talking about it collectively for a while, about these issues in relation to really failures in use of the mental capacity, the intersections between the Mental Capacity Act, the adult safeguarding regime. Sam's particularly talked really interestingly in the past about the kind of self-neglect not being seen as a safeguarding issue, but these lifestyle choice phrases kind of echoing perhaps in those less good assessments you were referring to, Barney, as being a kind of, there's a piece out there of kind of system failure, really, particularly from our perspective in mainstream NHS land, perhaps in A&E, perhaps within patients in acute trusts. And we've shaped a little proposal to say perhaps we should, and certainly maybe building off the work, Barney's work and that Mental Capacity Act guide, begin to think about producing some bespoke training or tools or materials or something to help improve practice in that space, but perhaps thinking about specialist colleagues on the call, as it were, but also perhaps tools that those specialist colleagues themselves would use to take more to mainstream colleagues in A&E or in other settings out there where our clients, our patients might rock up. So that's the kind of, that's as far as we've got, I think. Sam, Dee, would you, either of you, like to kind of jump in? But we'd be really interested in people's, does that feel sensible and useful? Because there's also a policy angle to this as to whether we should then be building some kind of, on the back of some of that thinking development, what are the wider things that people might want us to argue for in terms of system change or in terms of funding? Because through that network, we will have some feedback into the DH, as I said, into NHS England. There's a potential to do some system influencing, particularly if we surface a need, I think.
Okay, so Sam, if you want to go, and then Dee, if that's all right, and then anyone else who's got comments or experiences to share, if you either put your hands up or make yourself known in the chat, and we can get a conversation going. Sam.
I mean, it's really interesting being back in the hospitals again with the DHSE grant, and just witnessing again and again and again how little the basic connection between someone's cognition and their mental capacity is made. I just think it's astonishing, really. But also the sort of the lack of exploration around people's communication, going from, you know, language, literacy, mental health, psychological trauma, neurodiversity, all of those kind of things that are impacting on it, and people being very reductive, and also not really, I think, fully understanding how to do a mental capacity assessment. And I say I commend your stuff, Barney, because I always take out those forms. I'm very experienced, but I know that I will forget to do it properly unless I kind of really think it through. Just to say that, so the LNM has been involved with Fair Health, and we've done a couple of e-learnings for them on street outreach and stuff like that, and they're getting quite a good pickup. So just wondered whether it might be possible to do something that sort of gets people thinking about cognition and communication and its impact on mental capacity, that could go for the inclusion health sector, but could also be, you know, seen as the gold standard to be rolled out, for example, in A&E. I think it's I think lots of people don't know what they don't know, and if we could could have something really gentle, interactive, interesting, whatever, you know, I think we could get quite a lot of traction there.
Thank you, Sam. Dee, over to you. Sorry to keep you waiting to speak.
No, Sam has said it all. It was just to make the point that this is about I think the missed opportunities in mainstream A&E that are caused by the lack of awareness that Sam is talking about are just so important, and I see it as a really important opportunity to start to bring about that system change, to start to hook in other services who should have responsibility for people who've got huge vulnerabilities. So I think this idea of Sam's is the key to an awful lot of other really interesting work.
Barney, your hands up.
Yeah, I suppose I was going to refer to there's actually a round table with ADAS I'm attending next week, which I think that, you know, it's quite timely with them as well, bringing it up, and I think it is trying to sort of, you know, it's trying to break down those sort of barriers between that, and I think one of the things alongside training which has come out of some of the SARS, and I think there are ways of doing this, of street homeless people who've died on the street and there's been issues about mental capacity, is expert advice, you know, and legal advice. And I feel there should be a role, and this might be where things like ADAS come in things like emergency duty teams and social services, making themselves more available with timely advice around mental capacity issues and DOLs and that sort of thing for healthcare workers. And I think the other thing I'd say is ambulance services. I think so often when people are street homeless, and there were some really nasty near misses last winter, and certainly the guy who died in the bus stop in Hackney, where there were a lot of people articulating quite clear concerns about someone's capacity, which weren't incorporated into the thinking of ambulance services when they attended, and it was them who ultimately had to make a choice. And so I think that's a really, really important area.
I think that's absolutely true, Barney. I remember a lot of cases last winter when the ambulance services seemed to make assumptions about people capacity, which we disagreed with, really. And what you said earlier about the sort of people with the least professional training, the homeless outreach worker having to kind of argue with the ambulance services that someone didn't have capacity, it seemed a very difficult position for them to be in. And what you're saying about the I guess the trauma experienced by those frontline workers, I think if they get into those arguments and don't feel listened to, then people aren't going to stay in the sector, I imagine, because it's too much trauma. I was also going to make a point about Care Act assessments, because Capacity Act is one thing, and I don't know what other people's experience of Care Act assessments has been, but we often get them coming back saying people don't have any care and support needs, and that seems quite the opposite to us. And I wonder if there's something about, so I guess all of us, I can see lots of heads nodding to everything that's being said, and I guess all of us on this call kind of get it, and it's slightly preaching to the choir, isn't it? I wonder what we can do, and if you, Alex, or anyone has any thoughts about what we can do to make wider services access this training, you know, people who might not be so open to it. Is there anything we can do for that? Dee, your hands up.
I think the first thing would be to gather the evidence. I think it's really, really important to start counting this and capturing it, so we can begin to start to have conversations with DHSC and others. I think the second thing to say, and this is a long-term goal and not something that's a quick fix, but we need to be playing this kind of stuff into the conversations around the health disparities white paper and health and social care integration, that social care is part of the response to people experiencing homelessness. So we'd be really interested in looking at that in our conversations around the white paper and influencing that way.
I think I'd add to that, Jenny, and the who knows how effective it is, but working through the kind of connections that we have and colleagues have into bits of NHS England to see if we can begin to get. So I don't know whether people have picked up, but it looks like NHS England is going to release some, I'm not sure it's called guidance, but some good practice materials for English A&E departments in relation to homeless patients shortly, because Bola Owolabi is going on about it. I think it's going to be 10 top tips for your A&E department. I think significantly based on some work Sam and colleagues did a bit, and a paper written just before the pandemic. So that's good. I don't think it will say very much about what we've just been talking about. And then there's that parallel nervousness that you always get when you talk to A&E colleagues of just how busy they are and how stressed. And are you asking me what you want me to do more? Kind of, do you know how busy I am? Kind of, don't give me hard things to do because I'm up to here, as it were. So there's that really tricky balance, I think, for us, particularly in relation to A&E, but some other services who all feel under incredible pressure, don't they? And I was wondering also your insight, Barney, about the quality of assessments becoming shallower. Is that because services are so constrained? They know they have not very much to offer, and therefore they're it's a kind of denial of service. Like, well, actually, the needs are not high enough to get over our threshold, so I'm not going to, because our threshold's gone through the roof, really. So why write it up?
So, I mean, it all seems linked together, doesn't it? I always feel fired up when I come to these meetings, and it's happening again. That you're absolutely right, Alex, that the mental health services are, when I was a junior doctor, I sound like someone about 80, in my day, we used to write these thorough discharge summaries. We used to have a lot of time to sit talking to the patients, and you get to know your patients quite well, and you sort of get the feeling that some of that has been lost, and people are doing the sort of minimum required, and discharge summaries now kind of say someone came in because of this and they left on this medication, and it must be very dissatisfying for everyone. For the patients it's awful, but for the doctors I imagine it must be very unsatisfying not to be able to use that skill. So it just feels, again, as always, like us in this room have something to, we have to be making a case, don't we? We have to be advocating for better practice for everybody. And I wonder if there's comments coming up in the chat. I just wonder if we need to, as you say, gather evidence, and whether that's something that some of your money could go to having a sort of collection of this evidence and using it as a tool to beat people around the head with, as we like to do.
I think certainly from the call today, we'd be very interested in people getting in touch. As the nature of these kind of projects, we'll want a steering group, as it were. We'll want some people to help us shape it, and some of that might well be trying to gather some case studies. Are always powerful, as we know, that kind of illustrative materials of where things, but you need where things have gone wrong, but we also need to show how you can make things better at the same time. What are the things we could put in place which might relatively quickly make life easier? I think John Connolly's on the call. We got a small grant, and John did some trauma-informed communication skills training development, and he did a session. I think, John, are you there with the UCLH A&E team? My recollection was they kind of bit your hands off as soon as you began to explain just some of the things which might be happening. That was just a little training intervention, wasn't it?
Yes, indeed. Yes, I think, as Sam was saying, I think we all have our natural limitations in terms of time, knowledge and practice. And I think, yes, people are always incredibly grateful for any kind of guidance and support. Absolutely.
Yeah.
And those A&E colleagues seem to... Sorry,
I was thinking that it's part of it, the lack of time, and part of it is not knowing what to do, and sort of that kind of fear and anxiety can come out as anger sometimes, can't it? I'm sure John knows more about that than me. I just wanted to ask, is it Limia, I'm not going to say this right, Limia Cumberledge, who's made a couple of points in the chat?
Yes, hi.
Would you like to come in?
Yeah, I could just go by Lily. That's easier usually.
Lily, thank you.
Sorry.
Just I was interested in what you said about firstly the experience with 999 services, and also about the moral distress of not being able to care for people properly. I wondered if you could talk more about that.
Yeah, I guess the bit about the sort of 999 calls, I used to be a frontline worker in a homelessness service here in Edinburgh, and a couple of years ago we had a really horrible winter, and so I was one of the people who had the night phone, so sort of our hotline essentially, and so you get phone calls from members of the public, especially saying, I've walked down the street and I've seen this person here, and why aren't you doing something? And sort of getting 10, 15, 20 calls about the same person, having said, well, actually, I phoned raising a welfare concern. I've phoned 999. I've explained how concerned I am. I've spoken to police. I've spoken to ambulance, and saying, could you, as a member of the public, also phone, perhaps, because maybe that will sort of build on. And unfortunately, for one of the people that ended up having fatal consequences, they sort of died a couple of nights later as the result of exposure. And I think it was 2 o'clock in the morning, and then 3 o'clock in the morning, and sort of all night there was these sort of phone calls. And I think that was a really frustrating experience of sort of not feeling like I had the right language to necessarily be able to really lay out the argument. And at some point, remembering a colleague said, you just need to be really bullshy and say, actually, can I get your name? Because if this person dies, it's not just on me, and I want that recorded. But the real frustration that came with that. And then I guess overall, my thesis is sort of looking specifically at PTSD, secondary traumatic stress and burnout in frontline workers, and looking at the individual factors that get talked about, like personal coping style, but also more importantly, organizational culture. And probably not a surprise to anybody on this call, but organizational culture actually explains more of that for everything. And the coping mechanisms actually that do explain any level of distress are actually things that organizations have a huge amount of say in. So things like self-blame or sort of self-criticism in particular. That's one of the only coping mechanisms that makes it more likely you'll become distressed. But when you work at a blame-heavy organization and the incident report has worker responsible at the top of it, no wonder you're going to end up blaming yourself on things or really feeling that sort of quite strong guilt. So I guess that's sort of the moral distress that comes into that, not being able to do the work that you want to do or being the professional that you want to be. But then on top of that, also working within settings that are just deeply traumatizing also for workers, I think is a really big thing. Yeah. Sorry, let's be like a...
If I may quickly jump in, picking up on what Bernie was saying earlier on, I think that's where there could be a link with reflective practice. That reflective practice is the social ownership of a team with those feelings of disempowerment and frustration, so that the individual self-blaming natural responses become shared as a team, which then can be taken on board by the system.
Yeah.
And I think that's the power of reflective practice. And I think some kind of study regarding that could be absolutely invaluable, in fact. Yeah. Exactly your thesis, possibly.
I mean, I think, and unfortunately, I've not been able to do any qualitative stuff, but I have put together a sort of measure to try and evaluate reflective practice. But I think, well, it's not particularly far along yet. But I think there's also just something about trauma-informed supervision as well. I think supervision often becomes line management and very quickly becomes are you fit to work? And it's much more acceptable to say, oh, well, we're all a bit burnt out, than actually I'm really, really traumatized by the work that I'm doing. And what I'm having is not just exhaustion, it's actually I'm having trauma responses when I come to work, where I think that trauma-informed supervision, reflective practice is really, helpful and nurturing when people are experiencing that. So, yeah.
I mean, it's so interesting to hear about, Lily. There's a lot of comments in the chat about what a wonderful thing you're doing, and those that description of being on the streets of Edinburgh, seeing somebody freezing to death is just heartbreaking, really. I remember that we actually had similar situations last winter, luckily, not with fatal consequences, but it was absolutely just luck. And the same thing of lots of outreach workers, me as a professional, lots of other professionals saying, somebody needs to do something about this, or and then at 2 a.m. or the next morning coming into work and seeing that the ambulance had been, the outreach workers had stayed with the person for 2 hours and put their point across and shown them the emails, and still nothing had happened. It is really, really soul destroying. So there's a lot of interest and people who are keen to get involved with this. So Phil Timms, I think, has now left, but he's asking if anyone wants to collaborate in putting something written together on this subject. And maybe he's put his email if people want to get in touch. I've just put my email address in the chat too. Elizabeth, I noticed your comment earlier. I wondered if you wanted to come in, Elizabeth Ferber, with your.
Yeah, hello. So what was I commenting on earlier? Oh, about the Mental Capacity Act and the Care Act. I think that in general, like what we're seeing is the stripping back of services over the past sort of 10 plus years. And I think that sort of how I try to manage within a system that's constantly rejecting the people that I am trying to work with is by considering, within that, I mean, I suppose it's a bit like what Lily was saying to an extent, but just considering what creates the circumstances where somebody who's clearly got really high levels of need is spoken to by a social worker for 10 minutes, and then that's apparently a Care Act assessment that's ascertained that there's no eligible support needs. And I think it's working within a culture that's sort of grown up due to over 10 years of austerity, but also I think increasingly through kind of stories that professionals tell themselves using I guess, sort of perversions, I'd say, of different theories. So within mental health services, we've got the recovery model that came from, you know, service user led movement, and it's somehow been sort of twisted into an excuse to not provide a service to people. And similarly, within my adult social care colleagues, they'll say, we're using a strengths-based model, therefore we will not be going round to this man's house to provide personal care because he's a drinker, and we want to make sure that he uses his strength not to drink. And, you know, it's absolutely perverse, but I think it is, you know, it's part of, you know, austerity, the fact that people are working with nothing and they have to tell themselves these stories in order to be able to, you know, sleep at night. And, you know, I think that I do a lot of training around kind of Mental Capacity Act and executive capacity for social workers, for social work students, for newly qualified social workers, and they want to know about it and they want to hear it, but there needs to be kind of, you know, higher level structural change, I think, as well as equipping frontline workers. And yeah, I don't know how you do that because I'm a frontline worker, but that's what I've kind of observed.
Thank you. So again, it's so interesting to hear that everybody is having these same experiences and everyone's getting frustrated by the same things, and how we can harness that power and that knowledge. I saw your comment, Sam, that it's self-doubt, because if you keep being told that that you're wrong, then it's hard not to think, you know, am I right? So I think that's one of the beauties of groups like this, is that we can share these experiences, and there's something about that collective consciousness, isn't it? So I think the two things coming out are maybe John's need for reflective practice, the need for a chance to think about your feelings and to share them and to not feel all alone, and then sharing with the wider group as well, and then how we can change things. We need to use this to change. So I don't know, Alex, is there any, you've got all these different things that you're involved with. Well, what can we do?
Well, I mean, a couple, actually, I see Elaine Goodwin, who's from NHS England, just trying the corners, put her hand up. Elaine, I wonder whether...
Hi. Yeah, sorry, I have come into this halfway through the discussion, so apologies if my point's slightly off track, but yeah, I absolutely heard all, you know, the last sort of 10 minutes, and can resonate with some of it sort of from a personal perspective as well, in previous roles and in my own private life, trying to get help for people on the street. But I just wondered, just thinking about the gentleman who sadly died in Edinburgh, and Jenny, the example you've just given of, and I'm thinking a bit broader here, but how, and this is reactive, and I get that, but from those, say, two cases, for example, how were they picked up as an SI review? That was kind of just what I was wondering, and whether or not are there any, could there be any opportunities to look at this through the new patient safety strategy lens to try and get more sort of traction and yeah, system-wide ownership of kind of, you know, these sort of circumstances? Because I think, you know, do we sometimes, I'm assuming through current processes that sometimes that's missed. So the example being that we know somebody dies homeless on the street doesn't automatically get recognised by the system, does it?
I think also it's this person didn't die specifically on the street, but sort of but was very, very ill as a result of being in snow for, you know, a night with other existing health issues. And I think it was a couple of days later that that he did die. And so there's also a bit of a false association that happens where people are like, oh, well, unfortunately, homeless people have very high mortality rates, as opposed to, right, okay, but sometimes those are also as a consequence of systems sort of failing people. So I'm also thinking about people who've been in hospital and then are discharged basically back into homelessness, especially if they've got no recourse to public funds, and then end up back in hospital and then back on the streets, or sort of in really unsuitable accommodation, and then end up dying or having really significant complications. We had somebody who had an abscess in his leg, and a month later his leg had to be amputated, and the infection had spread up his groin because he'd been discharged back into homelessness twice. And that doesn't then get picked up necessarily in things like briefing note reviews or in sort of case review notes, because it's a, well, that's an unfortunate consequence, as opposed to seeing the pathway that that's gone down. Yeah.
One of the things I'm trying to get traction on nationally is around mortality reviews. Well, I suppose it's safety reviews, because we don't want to get to the mortality point, do we? But and I think just some of the conversations we've touched on today, I'll kind of take back into some of that thinking nationally, because I do think maybe the new patient safety strategy might be a bit of a hook as well, that we can try and look at this, raise the profile around it. But yeah, I was just sort of sharing those thoughts, really.
Thank you, Elaine. Sam, your hands up.
Yeah, it was just a quick one to say, I mean, it is a little while ago now, but I did refer somebody for a safeguarding adult review after death in one of the London boroughs, and they didn't take it because they said they'd done similar things to that one, and you know, they're expensive, and they didn't think there would be anything to learn from it. Just to give you that feedback. We've had a death on the street recently of somebody who was a multiple frequent attender. There was a case conference, there was a plan put up in A&E. A couple of times he wasn't taken in, then he was, and unfortunately he skipped his doles and did die on the street. It's a sad case, and it will definitely be looked at within the hospital and the hospital systems. But the other thing I was going to say was just exploring it within the hospital is massive, and I think if we want people to take it further and raise the profile of these things and whatever, we need to give them support to do it. I mean, I know of deaths on the street, you know, in London in this last year, and I know they haven't all gone to SARS.
Yeah, I think I wonder if some of that ties in with the self-doubt things as well, and the feeling that you've done something wrong. It's hard to make a noise and say this is wrong when you're thinking maybe it's my fault and maybe it's going to come back and people are going to blame me.
Exactly, and I think there is an element of that as well. People start panicking, they're looking at their own processes and what will happen, rather than thinking of the wider issues of, you know, this is it's systemic, and a bit like the original one, Barney, that led to your mental capacity guidance, is what can the system learning long term be about this? But I think people immediately silo and start panicking that you're right, that they somehow have done something wrong or didn't do something quick enough or whatever, rather than thinking, how can we collectively learn from this, which is a shame.
And Lily has put up a webinar, is it, that you've written or you've made?
Yeah, I did this webinar last week, so some of it will be quite intro level, I guess, because most people, well, everybody on the call will have a pretty solid knowledge of substance use and trauma in sort of a homeless population. But there's a brief overview of the research, as it's not submitted yet. But I also sort of brought in a bit of a compassion focused therapy lens to things, and sort of thinking about threat systems. And that's been quite a helpful way. I used to work in an addiction service, and that was a really helpful systemic lens to take. And I think it extends quite easily to sort of homelessness as well. So I'm happy to send the slides over to people as well, if that's better, if you pop me an email or a message on Twitter.
Fantastic. Okay, I think it's a shame to wrap this conversation up, but we need to. Our next speaker is here, which is fantastic. Do you want to introduce yourself? So it's Psychiatric and Gp Trainees. I must say, I'm really interested in this because we've got a GP trainee in my Croydon service, which is just wonderful, you know, because we have so many people with coexisting mental health, substance misuse and physical health needs, of course. And now we've got a GP trainee who can be more of an expert on physical health than I am. I think it's the future. So over to you.
Well, I'm so glad to have been invited. I wanted to say big thank you for letting me take up a little bit of time. My name's Rupal Shah. I'm a GP half the week, and half the week I work as Associate Dean with Health Education England, and I'm seconded to the School of Generalism now, which is not about GPs. Funnily enough, it's kind of promoting generalist skills in all new doctors, and hopefully extending out to a multi-professional kind of audience as well. So I've got, I think, 4 slides. Can you see that? Is that visible? I'm never quite sure with Teams. Brilliant.
Yeah.
So generalism is instilling generalist skills or enhancing generalist skills in all young doctors in the first 5 years of after qualification and hopefully a multi-professional offer as well. Each region in England, and this is an English project, is doing something slightly different. And in London, we're doing a project called Thinking Together, whereby groups of GPs and psychiatrists, or GPs and paediatricians, GPs, paediatricians and CAMs, hopefully extending out to elderly care, kind of have some learning sessions together, but also kind of form a group, a sort of ideally a little community of practice that kind of carries on the conversation apart from the formal learning. So it sort of arose from the NHS People Plan and the HE Future Doctor Report that generalist skills are important and not just for GPs. So there's kind of 6 domains, which I won't bore you with, but really relevant is social justice, I think complex multi-morbidity, person-centered care, that are systems working, which I think are all themes which are highly relevant for people who are homeless. So these are some of the learning outcomes: improve cross-professional understanding, improve individualized care, consider the impact of social determinants of health and systemic bias, which I think particularly for the homeless population is hugely significant. To recognise the limitations of applying guidelines and evidence-based medicine in complexity, which comes with real life. Improving communication between teams, and kind of thinking about how we regard physical versus mental health, generalism versus specialism. So as I mentioned, the domains in this sort of generalist school, which are particularly relevant: social justice, person-centered practice, population health, complex multi-morbidity. So we've got a few pilot sites, but the one that's running at the moment is at NELFT, the North East London Foundation Trust. It's groups. It's a group of core psychiatry trainees and a group of GP trainees. We've got only 4 formal sessions, but they've got a WhatsApp group going, and they're looking at hopefully some quality improvement activity around improving kind of communication between psychiatry teams and general practice. One of the sessions I've invited Caroline Schulman to lead, who I'm sure you all know, and I'm very excited to have a couple of patients who are going to participate as well, Jeff and Mandy, who I don't quite understand the link, so I don't know if you know them or not. Some people are nodding, but it's going to be sort of very much about lived experience. We talk about narrative, we talk about injustices kind of inherent within the systems in the formal learning sessions, and there'll be a sort of slightly different model for pediatrics, but you know, really relevant themes, I think, talking about adverse childhood experience, you know, including homelessness. And so, you know, the bottom line is I would love to collaborate with you and kind of, yeah, I'm not even sure how, but I think there must be an opportunity, and I'd just be delighted to kind of be linked in with you, I guess.
Thank you, Rup. That sounds really like the future, I think. As I say, it's so good to have a GP in our team, because it feels like the sort of paths separate, and then people don't think about the whole person, which our patients need to be thought about as a whole. And I think it's been really good for the GP to see psychiatric care and take that into what they're doing in the future. But so the more we have of that, the better, I suppose. Lucy, is it your hand up?
It is. I'm really sorry. I can't have my video on.
We'll forgive you.
Thank you. Rupal, I'm a GP. I work in the homeless mental health team in Hull. Rupal, we've been contacted to support some work with a generalist pilot in Humber called Enhance.
Yes.
But with,
yes, it's the same pilot.
It's the same thing. I was wondering, because when she sent the email, she said they've on attending theirs, they're going to have lots of people from the trusts, local hospital trusts, which is interesting. That seems to be where they've gathered their people from. So I'd be really keen to know a bit more about your programme as well, because they've asked us to kind of help, I don't know, put forward some ideas and different suggestions. So it'd be good to look at what you're doing too, if that's possible.
Of course. Would it help if I shared the course program with you separately?
Yeah.
I mean, I could email it to, I've got Alex's email address, I think, and Sophie's. So
yeah, thank you. Because we're looking at inclusion, a lot of inclusion, some inclusion health stuff too. So it'd be good to see how that could, what you're doing, and maybe there's some cross-pollination, I don't know.
that would be brilliant. I mean, the funny thing about London, so every region in England has is approaching enhanced generalism in a completely different way. So this is a sort of London-specific program. And the kind of interesting thing about London, I started in September, so I started probably a year later than other counterparts elsewhere. And it's kind of really me and a senior project officer who are the London generalism team, which is kind of interesting.
Sounds
and
similar to Hubba and the lady doing it there.
But yeah, so I would love to start a conversation. I'll email the sort of specific course program to Alex and Sophie, and perhaps
yeah, that sounds great. Thank you.
I was just thinking how this links to the conversation that we were having as you came in, Rue, which was about sort of missed opportunities for intervention with people on the streets and people ending up dying because of thoughts about capacity, and care act assessments aren't being thought about in enough detail. And of course, GPs are a big part of that, because certainly GPs who work with homeless people are also involved. And thinking it's sort of, we have this meeting for mental health, people who work in mental health. So am I saying, you know, everything should be thought about the whole person, but we do sort of separate into groups. Alex, is there a similar group for GPs?
Good, very good question, of course, Jenny. We have, I mean, very recently we've begun to convene who we call our kind of pathway team GPs as a little group, particularly just to support up some of them, as we've supported the launch of several new teams in London and elsewhere. So beginning to support them as a network, but we are actually just, who knows whether we're getting it, we're bidding to the BMA, have put some funny money out, which we're going to try and bid for to create a more of an activist specialist inclusion health GP network, but it will be a 1 year thing, I guess, if we get the grant. So it's something we'd really like. I think there'd be real value in it. It is this, I think there is something, isn't there, about tribes. Tribes need to meet in their tribal territory as well as, and need to be safe at home as well as coming out to the big intertribal gatherings, don't they? We need to do a bit of both, don't we?
Absolutely. Yes, it does feel like I'm in my tribe at the moment, but I'm sure, you know, the same frustrations must be happening for GPs and physical health experts, and the power of trying to change things, I guess, is stronger if people are working together, and voices are heard from, you know, all the medical colleges and whoever it might be, to show that this is, you know, people are thinking the same thing and finding the same things unacceptable. That will, you hope, would drive change.
I think so. And that generalist, I mean, it's the push, which is we've been following for years, the push towards bringing generalism a bit more back to, not that it ever completely went away, but being more of a focus in the medical training curricula, feels like it must be a good thing. I don't know, Rue, what's your view of that? I mean, are you a kind of evangelist for it? Do you think is it going to change things?
I really hope so. I think if I didn't believe in this quite strongly, then I wouldn't have taken the secondment.
Of course.
So it seems, you know, the longer I'm a GP, the more ridiculous these kind of artificial boundaries feel to me. That even the idea that physical and mental health are separate, you know, I would really question. So I really hope so. You know, I feel there's so many structural kind of issues, aren't there? And in terms of really embedding a program like this, I really hope so. And I think that if we're kind of working not in silos, if I kind of understand what else there is, and I'm kind of linked in, then there's more of a chance of success, because this is you know, there's everybody wants this program to succeed. So there's a strong kind of political drive for it to succeed in London, and so I'm really hoping that it will.
the other piece that we've, I mean, again, which is back to the earlier conversation, Health Education England, of course, is a very significant part of the NHS infrastructure. And there we were talking about, I mean, the amount of funding we've got to think about developing our little programme around mental capacity is like £5,000, which is really not very much, as it were.
No.
But whether we can begin to think about organisations like HEE, which do have the responsibility for the large scale training of our health system, beginning to be influenced, and actually that the conversation we're just having about making the case for reflective practice and those kind of the psychological support that staff need, and getting that much more recognised, which perhaps is also part of some thinking about generalist. What in general, what does everyone need? I suppose is another angle, isn't it?
I would, any suggestions that you have, or anything that you think we overlap on, I would just love to hear about it. I'm sure there wouldn't be time right now, but I would just be so grateful for any thoughts about how there is overlap and how we should be working together and kind of exactly feeding it into the HE machine. That would be really great.
Well, perhaps you and I could definitely pick up an offline conversation.
Please.
Perhaps with Sophie, we could kind of connect and think about
I'd
some
love
of
to. I'd really,
some of the
really
tactics
love to.
that.
And do you know, Rup, if there's other sort of areas of the country that would like such a scheme, or because it does sound like it's the future, is there any way that people can request it or take it forward?
So enhanced generalism applies to the whole of England. It's just that other regions are having a slightly different take on it. I think, and I can't remember exactly who's doing what. I think Humberside, but there's certainly a region, and somewhere in the northwest, where there's a huge focus on homeless medicine and you know, kind of core medics going out into and sort of working with homeless people. Everyone's doing a slightly different take on it. I think the reason I conceptualized it like this was because there was no extra funding, so I couldn't really say to trusts, can I have permission to take your you know, your core psychiatry trainees out for half a day? So it was all sort of based on budgets and, well, can you spare 2 hours, you know, for 4 lots of 2 hours, and then, you know, some offline work, which trainees have sort of you know, formed this WhatsApp group, and they're looking at how they can do some quality improvement in their own time, really. I don't know if that answers your question. I mean, homelessness features within most of the regions kind of offers, I think, on enhanced, not everywhere, but it features quite prominently across England.
It's definitely a really interesting thought that you could have sort of specialist homeless doctors who can do a bit of everything, prescribe your methadone and do your leg ulcers and prescribe some olanzapine at the same time. It doesn't feel like it should be beyond the wit of man, doesn't it? I think that people like Lucy are the vanguard. I'm just also thinking about outside of England. I know Lily in Scotland, and we had someone from Wales in the call earlier. I'm just wondering if other British countries are doing anything similar. Scotland always seems quite at the vanguard of things.
I know there's been stuff sort of in nursing and general practice. Fiona Cuthill at Edinburgh has done sort of quite a lot of stuff there. And they also had a master's in inclusion health, I think, that frontline workers could access, which was really, really cool. So I have some colleagues, former colleagues, who did some of that. But they'd also done, so John Budd, who's part of the Edinburgh Access practice, recently published an article comparing sort of some of their sort of outreach type work between Glasgow and Edinburgh. So I think there is quite a lot of GP interest, definitely. And I think you've then got people in various services outside of general practice who are interested definitely in linking in from sort of a more medical standpoint. But yeah.
That's interesting. Maybe we need more cross working. I think more buddying up. I think you mentioned the masters in inclusion health, and I think everyone nodded their heads thinking there's one at UCL as well. Is that what you were going to say, Alex?
Yeah, I was also going to say that as I understand it, the medical royal colleges in general have signed up to the turn toward generalism. Certainly, some of the recent meetings Nigel and I have had with the Royal College of Physicians, they've said no more specialties for the next no more new specialties to be anointed for the next few years because they feel that's gone as far as perhaps it needed to, or even a little bit further than it needed to, and let's this turned back towards whatever the language you use, holistic or more person-centered or whole person. I think has been brought. There's been a statement endorsed by all the medical royal colleges, I think.
Yes.
And that's kind of blessing it, and that will be presumably across the UK, I think. So there's a endorsement at that level, and it's really interesting to see people like Rue now beginning to drive it in practice. The kind of concept having been accepted.
Really looking forward to some more conversations. I'd better rescue the people from their their breakout rooms from the other course. Not leaving them
Okay, well,
stranded.
thank you so
Thank
much.
you so much for
in.
inviting me.
Thank you. It was great that you could fit us in, and we'll stay in touch.
Definitely.
Get us thinking.
Bye.
Okay, well, that kind of is the end of the agenda for today. I wondered if anyone has anything else that they'd like to discuss or any other business, please let us know. And well, yes, please put it in the chat if you do. And also we need to think about our next meeting and what would be helpful to, if there's anyone who'd like to present at the next meeting or anything that people would like to talk about at the next meeting, please either stick your hand up or say in the chat or get in touch afterwards if you'd like to. I think today's meeting has been excellent, and I need to thank Sophie for organising it and thinking of the agenda, because it's been really, really good to connect with everybody. I've really enjoyed it. As I say, I always feel fired up, and I do again. Does anyone have any closing remarks? Alex, you always have some closing remarks for us.
But I mean, to echo your thanks, Jenny, thanks for everyone to coming. I think that was a really powerful discussion earlier, and there's so much there to go away and think about. I hope colleagues have found it helpful. I guess I'd point you at the Pathway website, the faculty. There's a faculty page on our website. Just if you did have a moment, go and if you're not sure whether you're signed up to the faculty mailing list, maybe you're not, go to the website, sign up as a member of the faculty, and then check the mental health subgroup box, which will make sure you're on our mailing list. But so we'll be using Teams to keep the invitation to these meetings going, but we're trying to also have that open access so people can sign up themselves. Again, if you've got colleagues who you think might want to take part and want to join the network, please do share the details with them.
Yeah, I was going to say the same thing. So it's great to have so many people here today, but I know that there are more of us, and the more of us, the better. So please share with your teams. I'm going to do the same. And I guess the next meeting should be the beginning of June. Is that right?
Yeah.
So any thoughts? I think I've put my email address at my Twitter further up, so you can get in touch with me. You can get in touch with Sophie with anything that you would like. Lily, your hand's up.
Yeah, I'll have done my Viva by then and hopefully passed it. So I'd be quite happy to, I guess, provide a bit of a summary of the research and the findings, if that would be helpful at that point.
That would be absolutely wonderful. We'll sign you up right away.
Okay.
I'll get in touch with you to arrange that then. The next meeting is the first Tuesday in June, which will be the 7th of June. So put it in your calendars now, and we'll send a save the date for that as well. That is the week of my Viva, so I'm gonna put a caveat in that I may be
we'll postpone it.
in full of stress about my Viva, in which case people can suggest tricky Viva questions during the presentation.
Yeah, we could do a practice Viva. That would be if we don't actually clash with your Viva, that would be a bit much, but we'll make a plan, because that would be fantastic. Okay, let's call it a day there then. Thank you so much, everybody, again for coming. It's been really good to have this meeting, and do keep in touch outside of the meeting, and we'll see you soon.